Sometimes we have to change as we go. But really, it's a great pleasure to see again some friends, even if at a distance. Today, we'll start with the 2021 masterclass cycle. This cycle that last year was an absolute success. It was wonderful. And we started it with a wonderful speaker too. So Kabbalah suggests that we should start with the same guest, with the very same guest that we had last year. So welcome, Dr. Klotz. Thank you again for coming with us. Introducing Dr. Klotz is absolutely unnecessary because beyond any titles that Dr. Klotz may have, I think that his contribution to uro-oncology has been incredible. 20 years ago, when as a surgeon, Dr. Klotz told us surgeons that we didn't have to operate on prostate cancer, it was very difficult to pay heed. Today, when all the guidelines say that active surveillance is an excellent first line option, it's very easy to do that. But 20 years ago, when Dr. Klotz presented his first series of 100 patients, saying this, you needed to be very brave to say this. You needed a great imagination and a great humbleness by surgeons, and especially to acknowledge that sometimes we can be worse to patients than the tumor itself. So thank you, the father of active surveillance, because you made us better physicians. The informal curriculum of Dr. Klotz is not a minor thing. Last year, I showed how yesterday on May the 1st, Dr. Klotz in less than 2 hours answered that he would be with us. And this year, it didn't take him any time to say yes to a group in the world nobody knows. So I thank you for having given us the opportunity to share time with you and for being able to and sharing friends as our friends Pablo Sal. So Dr. Klotz, you can go ahead.
Thank you, Levin, for that lovely introduction. It's really a pleasure to do this. I feel a connection to Uruguay, although I've never been, but my brother lives there now. He has a property several hours from Montevideo, and I am hoping to visit him sometime in the next year, as soon as the travel frees up. So I'm very happy to have this opportunity to speak. Let me just get my slides up. Is this showing okay? You can see? Yeah, okay. So this is Toronto looking at its best. Right now, we are completely locked down as of yesterday. Everything is closed except for a few necessary food stores. So it's very tough with COVID at the moment. And I think you have a similar situation in Uruguay and in fact, all over the world. Until a while ago, at least in my world, it was like the only disease that mattered was COVID and everything else was pushed to the side. But of course, patients get other diseases besides COVID. And in fact, I don't think we need to make any apologies to be talking about prostate cancer, which is still a very major public health problem, even with COVID. And in fact, I just wrote an article published in the World Journal of Urology comparing COVID to prostate cancer, because in my opinion, the public policy response to COVID, at least in Canada, which has been very drastic, is like treating all patients with low-grade prostate cancer with radical prostatectomy. It's heavy-handed, it doesn't work, and there are some lessons from prostate cancer that should be applied to COVID, but this is another story. And now I'm going to give an overview of where this field is at, and particularly some of the new tools that are available to improve the management of men with low and favorable intermediate risk prostate cancer. So Levin referred to the original publication. Now, that was 19 years ago. We had about 250 patients. We started in 1997, so it's about 5-year follow-up for this first publication. There were no deaths, and it really, yes, as he mentioned, it started a lot of controversy, which went on for about 10 years. And now, of course, a lot has changed. So first of all, there's no longer an argument about whether this is a good concept or not. And there is general agreement that overtreatment is a problem. We know much more about the nature of occult high-grade disease, that is, the patients whose disease gets missed by conventional imaging and systematic biopsy. We know about the value of baseline parameters like PSA density, extent of disease on the core in terms of predicting who has higher grade cancer. We know about the limitations of PSA kinetics. So for the first roughly 13 years, we used PSA kinetics to trigger treatment for patients. And then we went back and looked at this, and it did not work. It identified many patients who had insignificant disease, and their PSA increased because of prostatitis. So it is not reliable as a trigger for treatment, although it does identify patients at higher risk who need to be more closely scrutinized. We have MRI, which we didn't have, certainly we didn't have 20 years ago. We didn't even have it 10 years ago, but this has been a game changer, although it has limitations, which I'll talk about. We have robust modeling studies. We have multiple large registries now. There are probably close to 1,000 patients who have been followed more than 15 years in these registries, and overall more than 10,000 patients being reported on in prospective registries, and many publications, close to 4,000 publications now on the topic. So it's a very active area. So first of all, a summary of what is agreed upon, although there's lots of areas of controversy, but everyone who is in this field agrees with a couple of key points. First of all, that pattern 3 is very different from pattern 4. The molecular genetics of Gleason 3 in about 90% of cases are normal, where in higher grade cancer, you have loss of a tumor suppressor gene like PTEN, or you have amplification of an oncogene like MYC. In pattern 3, these are normal, like normal cells. What this means is that pattern 3 is a completely non-metastasizing cancer. And I think this is one of the key concepts to appreciate. If your patient has high volume Gleason 3, he has a higher volume of harboring higher grade cancer, but he has no risk of metastasizing as long as all he has is pattern 3. And this should not drive treatment. There is a controversy now, should we still call Gleason pattern 3 or grade group 1 cancer? And it would certainly make our life easier if we changed the term and called it something else equivalent to pun lump. I don't know if you have the term pun lump in Spanish, but in bladder cancer for completely benign papillary lesions. The difference between grade group 1 and prostate cancer and pun lump is that grade group 1 can show local invasion through the capsule or into the seminal vesicle. It's only about 5% of cases, but because of that, pathologists are reluctant to drop the term cancer. And I think we are still going to have to deal with calling grade group 1 or Gleason 3 cancer going forward. Just 2 large studies that confirm this observation that it's non-metastasizing. One study is 12,000 patients Gleason 6 treated with surgery. One study is 14,000 patients, and these patients were pathologically graded. So you don't have the issue here of the biopsy undergrading or undersampling a higher grade cancer. And in both these studies, 0.2% of patients had metastasis. But in both studies, when they re-reviewed those 2 per 1,000, they all had higher grade cancer in the radical prostatectomy specimen. So here in these 2 studies, 16,000 cases, not one case with metastatic disease, not one. Now, I've been collecting these rare cases. I ask audiences, does anyone here have a case of pathologic Gleason 6 treated with surgical confirmation who went on to have biochemical recurrence and metastasis? And there are a handful of cases that I know about, but it might as well be 0 because it's really maybe 5 cases out of hundreds of thousands. So you do not need to worry about metastasis with grade group 1. Now, what you do need to worry about is misattribution of the grade. That is, particularly with systematic biopsies, about 1/4 or 1/3 of patients will have higher grade cancer. With MRI and targeted biopsies, the figure is somewhere between 10 and 15%. So it's much lower, but it's still significant. In contrast, the risk of the disease progressing from grade group 1 only to higher grade cancer, of course, biology is dynamic, cancers dedifferentiate, but the risk of this is low in the short term. And the modeling studies have showed somewhere around 1 to 2% per year. The figure I use is 1.5% per year. So it means at 10 years, around 15% of patients will progress to higher grade cancer. But this is usually Gleason 3+4. It may not be a threat if it's an older patient. And it's also usually in a large field of grade group 1. So what you do not see is microfoci, small volume grade group 1 going to high grade cancer. This does not happen. Where you have a large field of grade group 1, you can get progression. This is our data based on serial biopsy over many years, and 1% per year was our estimate of the rate of true biologic progression. So I mentioned 90% of grade group 1 has normal molecular genetics, but there's an important subpopulation that has higher grade, that has worse genetics, that has more mutations. This is a recent study that looked at this, that defined the average genomic risk, which is a meta score of genetic aberrancy. And you can see the second line here is the grade. So light blue is grade group 1, dark blue is higher grade cancer. This is the heat map. It goes from normal molecular genetics to many aberrations, many mutations. And you see here 2% of grade group 1 had bad genetics, had a high metascore of genetic aberrancy. It's not 0. I think what happens is that most of these grade group 1s with bad genetics are on the verge of transforming to higher grade cancer. And so that by the time you manage these patients or rebiopsy them, they have higher grade cancer present. So patients need to be followed. You need to be alert to this. But I come back to saying, despite this 2% with bad genetics, we almost never see patients with grade group 1 prostate cancer who metastasize. The clinical data, I think, is pretty well known now. I just want to compare the top 2 series. These are the 10 or so large prospective series that are reporting. Some of these, like the Prius study at the bottom, has more than 10,000 patients. It's a multi-center trial now. And they have different eligibility criteria. And the 2 extremes are the top 2. Our series, which was very inclusive, patients with 3+4, patients with PSA as high as 20, we wanted to see how well does this work versus the Hopkins group led by Bal Carter, which was very restrictive. So only Gleason 6, only 1 or 2 positive cores. These are the Epstein criteria, no core more than 50% involved, and low PSA density. And now we have the results of a natural experiment. How did these 2 strategies compare? And this is our data published a few years ago. We're just in the process of updating this, but the figures still look roughly the same. 1.5% overall prostate cancer mortality. If you calculate the actuarial mortality as if all the patients had been followed 15 years, 5%. But in fact, only 1.5% of patients have died so far of prostate cancer. So when this was published, I thought it was pretty good until a few months later, when the Hopkins group reported their series. This is similar cohort size, 1,300 patients, similar follow-up, but lower mortality, 0.5% at 15 years. So they did better than we did, but clearly this was related to patient selection. And this shows that the patients who, amongst the intermediate risk patients who we included, the presence of grade group 4, of Gleason 4 or grade group 2 dramatically increased the risk of prostate cancer mortality. And this shows the PSA was not important. It was only the Gleason score. Now, you might say, this is not surprising. We know Gleason pattern 4 is worse, but we managed these patients very carefully. We treated them if it looked like they were progressing. And despite that, at 15 years, we had 30% mortality in the patients who had grade group 2 or higher at baseline. So what has happened over the years is we've converged. We have become more selective about the Gleason 3+4 cases. The Hopkins group has expanded its criteria to include all grade group 1 and selected grade group 2. So I'll come back to the grade group 2 patients. And so now our approach is pretty similar, and I think this has been adopted very widely around the world, that the management strategy of choice for most grade group 1 patients is active surveillance. And this is about 1/3 of newly diagnosed patients with systematic biopsies. With targeted biopsies, the percent of grade group 1 diagnosed drops about 50%, relatively speaking. So from about 1/3 to about 1/5 or 20%. But there is still plenty of grade group 1 prostate cancer being diagnosed, even with targeted biopsies. One of the questions is, how important is the follow-up protocol? So we have just published this. We went back and looked at how did the patients who complied with our protocol, particularly the biopsy at 1 year, and then periodic biopsies after that, roughly every 3 to 5 years. And, you know, in the oncology field, there is very little data showing that how you follow patients really makes a difference in terms of survival. But to our surprise, we found that in this area, it really did make a difference. So here you can see the red line is the patients who complied with the biopsy protocol. The black line is the patients who did not. There was a difference not in prostate cancer mortality and metastasis-free survival, and a trend to an improvement even in overall survival in the patients who complied. So you need to follow these patients with grade group 1. You need to biopsy them or re-image them, certainly follow them closely, or they will pay a price. And that is usually because they have occult higher grade cancer that you diagnose with your follow-up strategy. Now, one of the exceptions is the BRCA2 story, and I think everyone knows about this now, but just to emphasize the biology, which is that in sporadic cancer that you see in the bottom, it's a long process. You start with loss of some key tumor suppressor genes like P53 or P10, and then you go on over many years to acquire other abnormalities, gain of MYC and other oncogenes, genomic instability, methylation changes, and you get invasive cancer. In contrast with BRCA mutation, which is a defect in DNA repair, meaning that mutations which are occurring all the time are not corrected. This is usually a defect of double-strand DNA repair. Once you get the initiation of the first cancer cells, it's like there's an explosion of mutational events. This all happens very quickly. So if your management strategy is conservative with active surveillance, this is not good. This is a recipe for failure. And the data we have now, it's quite limited, but more is coming, is that in men on surveillance who have BRCA mutations, this is a study from Harvard, 26 men with DNA repair mutations, mostly BRCA2, the hazard ratio for progression to higher grade cancer was 2.7 with BRCA2, less with BRCA1 and ATM. You see here at 10 years, it's 80% of patients have progressed. My interpretation of this data is actually 100%. It's just they missed the other 20%. So if you have a patient, particularly with BRCA2, this patient, in my opinion, should be treated with surgery, even if they only have low-grade cancer. We also have some data, it's limited, that radiation is bad treatment for patients with grade group 2. There's one study from the UK, Professor Ellis, that patients treated with radiation had a much worse outcome with if they had BRCA2 mutations than patients treated with surgery. Now, the question is, how do you find these patients? And I don't know how well known this is now in Uruguay. This is becoming very well known now in Canada and the United States, that these assays for hereditary cancer mutations have become extremely cheap and widely available. So you see here, this is color.com. This is available internationally. The patient just goes online, pays either $100 or $250 US. They get a kit in the mail. The patient puts saliva in the kit, sends it back, and a couple of weeks later, you get a very high quality report, particularly of the DNA repair defects. So I now encourage all my patients who have any significant family history of prostate cancer, or on the women's side, breast or ovarian cancer, particularly of metastatic disease, to do this. And it's the science is very solid, and patients are really appreciative. Of course, if you find a patient who's got a BRCA mutation, then it has implications for his relatives because they may also be at risk. So by doing this, you may really have an impact on the health of the entire family. The next topic is imaging. And of course, this has been a huge advance. So just by example, this is a patient whose original biopsy for an elevated PSA showed 1 positive core, 10% Gleason 3+3. In the old days, he would have had a systematic biopsy at a year, which may or may not have shown anything. But today he has an MRI. I don't know if you can see the lesion. It's right there. So imagine trying to hit that with a blind systematic biopsy. You would have to be very lucky. In this patient, he had MRI with a targeted biopsy. It showed Gleason 4+3. He had a radical prostatectomy. This case is also illustrative because the actual size of the high-grade lesion was much larger than what was suspected on the MRI. And unfortunately, this is a consistent limitation of MRI, that it underestimates the volume of cancer by about 1/3. This is also a very characteristic case because the cancer was anterior. So its anterior cancers form a very substantial proportion of the patients whose higher grade cancers are missed on systematic biopsy. And you see here, he had a microfocus of 3+3 found on the biopsy that really was insignificant. The real cancer was anterior and was missed, but found with targeted biopsy. But how well does MRI work? And unfortunately, we now have a lot of data about the limitations of MRI, and they are very significant. This is from one center of excellence at UCLA. Almost 600 men with intermediate to high-risk prostate cancer who had MRIs followed by radical prostatectomy. How well did the MRI correlate with the actual disease in the prostate? And you can see on the bottom right here, these are the patients who had multifocal cancers. And you can see here that almost 80% of the cancers less than 1 centimeter were missed. 80%. It's shocking. And overall, MRI missed 40% of grade group 2 cancers, a quarter of grade group 3 cancers. So MRI is a huge advance, but it misses cancers. You cannot rely on targeted biopsy alone, and that message is crystal clear. It also, as I mentioned, underestimates volume. Here's another study from the same group that compared MRI volume to cancer volume. The mean MRI size, 1.6 cubic centimeters, mean size of the pathologic lesion, 2.4. So 50% greater volume of the actual cancer than seen on MRI. And this is something to keep in mind as we move forward with focal therapy. You have to assume that the lesion you see on MRI is smaller than the actual lesion. One more bit of data about the limitations of MRI, and this is data that I published. We did a randomized trial in men on surveillance comparing systematic biopsy to systematic plus targeted biopsy for the 1-year biopsy. It was 273 men. I thought for sure this trial was going to be positive, that we would show targeted biopsy, increase the rate of finding significant cancer in these men. We didn't show that. This is some of the worst MRI data that anyone has ever reported. First of all, there was no difference in upgrading. Second of all, even in those patients who had positive lesions, you see here MRI score 3, 4, 5. Look, only a third of the men with a PIRADS 5 lesion had clinically significant cancer. In contrast, this is the precision study from the group in London, England, not on surveillance cohort, but on an elevated PSA cohort, but still 83% positive predictive value of a PIRADS 5 lesion versus 33%. In retrospect, what our study did was demonstrate that there is a very steep learning curve for fusion-targeted biopsies. We actually showed in a subsequent publication that the MRI did have value because the upgrading rate was much lower over a 2-year follow-up in the patients who had an MRI, but it just is a cautionary tale. And finally, a study from Memorial Sloan Kettering that looked at how well did MRI predict for grade progression in men on surveillance. And the take-home message is not very well. About a third of men whose MRI was stable over 3 years were upgraded to higher grade cancer. And even the patients whose MRI improved, so they had a PIRADS 4 lesion that disappeared or that converted to a PIRADS 3, still about 20% of patients had grade progression. And one more study just published from the Canary active surveillance group on the West Coast of the United States and Canada, 361 men on surveillance. Basically, they showed what we showed, that the targeted biopsy didn't increase the rate of high-grade cancer very much. And the message, systematic biopsy required in patients, whether the MRI is negative or positive. So this leads to my next topic, which is some new imaging technologies to try and complement MRI. And one of the issues that we have in Canada, and I don't know how it is in Uruguay, but an issue we have is that access to MRI is quite limited. At centers of excellence, it's possible for patients to get MRI to access it fairly well. But in most parts of Canada, it's very difficult for a patient to get a prostate MRI. and particularly to get them repeatedly over time. So this is a new technology, high resolution micro ultrasound. I admit to some bias because this new technology was actually developed in my institution at Sunnybrook Health Sciences Center by the Imaging Research Group. And I first heard about this about 10 years ago because in my research lab, we were studying orthotopic prostate cancers in mice. And I connected with another scientist in the imaging group who had developed micro ultrasound that allowed you to image a cancer that was 0.5 millimeter. So this is useful in a mouse. And we did a number of very nice studies looking at in vivo growth of orthotopic prostate cancer by micro ultrasound. I never thought this would have a human application, but it did. And so these scientists commercialized this device, which looks like this, looks like a normal ultrasound, but it's 29 megahertz compared to 6 to 9 megahertz. The advantage of this is the resolution, instead of 200 microns, it's 3 times greater, it's 70 microns. 70 microns is the diameter of a prostatic duct. And so what it means is with this technology, you can see alterations in ductal anatomy that are not visible with conventional ultrasound. The change in ductal anatomy is exactly the same principle that results in restricted diffusion with MRI. So it really, on principle, allows you to image prostate cancer according to the same basic, that detects the same changes as multiparametric MRI. And this just shows what this looks like. So of course, the limitation of high resolution is depth of penetration. This is the lower resolution. You can see it goes up to about 5 centimeters. And this is high resolution, 3 centimeters. But you compare the images and you can see this is normal looking peripheral zone with the speckled white pattern, very uniform. And you don't see this level of detail with the lower resolution. And this just shows some other abnormalities that, again, are unique to this technology. This is called bright echoes or starry sky. This is associated with high-grade prostate cancer. Many of these patterns, I've been doing prostate ultrasound for 20 years or more. I had not seen these kind of patterns with conventional ultrasound. Now, partly I wasn't really looking for them, but with this technology, you really see them very easily. You see anatomy very clearly. There is neurovascular bundle, for example. One of the remarkable things is that you can see needle tracks. This is 5 years after a previous biopsy. You still see the needle tract image. So that's very useful if you want to go and rebiopsy the same area, find out if there's grade progression. And this is called the Primus grading system, which has been developed, obviously analogous to PIRADS. And just very quickly, you see this is normal on the left, this kind of Swiss cheese pattern of small speckled white and black dots. And this is very reassuring. My own view now is that if I see this pattern, I am extremely confident that this patient is not harboring a significant cancer in that area with about 95% confidence. And then you get the abnormalities. So I mentioned the starry sky. This is cauliflower appearance, so-called, where you get smudging, loss of the ductal anatomy. You get irregularity of the echogenicity. You can see the very subtle alterations in the prostatic capsule. And it's quite easy to learn how to recognize these. And this just is an example. So here you see a patient with an apical lesion, very typical, about 1 centimeter in diameter. And this was probably visible on MRI, but with MRI, you would have the procedure done. The radiologist reads it. Hopefully he sees this. He registers it. The patient is then referred for the ultrasound guided biopsy with fusion technology. You hope that the fusion technology accurately targets this, but it's 2 visits for the patient and many sources of error, as we demonstrated in the trial I showed earlier. In this patient, you do the ultrasound, you see the lesion, and you put in the needle and bang. You can be totally confident that you have targeted that lesion. And so it really gets around a lot of the potential sources of error, as well as a single procedure. And this is a new technology. It's been around maybe three years, but this is I recently published registry of the first 11 sites around the world that started using this. So this very much represents the learning curve. These 11 sites are from 4 or 5 different countries. It was adopted quite early in Italy, in Germany, and several sites in Canada, including mine. And so this is not perfect data, because it's not a prospective trial. The way the procedure was done, the level of experience varied, but it's an initial experience. And what it shows quite reassuringly is that the sensitivity for significant cancer was as good or better with ultrasound than MRI. And this is actually better than I expected, given the limitations of people being on the learning curve. The specificity was about the same. And this is going to improve with experience. And the metrics of positive and negative predictive value were almost identical between this micro ultrasound and MRI. And now this is blinded data. So not all of the centers in the data I just showed were blinded to the MRI when they did the ultrasound. That introduces some obvious bias. But the group in Milan has just reported this data, 320 patients rigorously blinded to the MRI. So these patients had an MRI, but the ultrasound was done blinded. And you see here, this is for each score. This is Primus 5 versus PIRADS 5. The likelihood of finding significant cancer was almost identical. It's uncanny how similar the performance of micro ultrasound is to the MRI in this study. So the caveats, it's preliminary data. There's less than 2,000 patients reported. We have level 1 evidence supporting the use of MRI from multiple prospective randomized trials. So the quality of data with MRI is much higher, but I still think this is a very valuable step forward. The next is biomarkers, and that really relates to the favorable intermediate risk patient. So the first thing is, should we be offering surveillance to men with Gleason 3+4, grade group 2? And the answer is we should, but selectively. The evidence for this is, first of all, from the pivotal study SPCG4, the randomized study from Scandinavia that compared radical prostatectomy to no treatment. We just had the 29-year follow-up. I believe this is the 4th New England Journal publication from this study, which everyone knows. This study provides the basis for radical prostatectomy in higher grade cancer. But despite the fact that we all point to this study to justify the benefit of surgery, I just want to point out in the Gleason 3+4, huge benefit to the higher grade cancers with surgery with a hazard ratio of 5 to 10, but for grade group 2, the 3+4 patients, no benefit of surgery. So this doesn't mean there isn't a benefit, because the trial had limitations, but it does mean many of these patients are candidates for conservative management. No mortality benefit for Gleason 3+4. So how do you pick them? So first of all, we have now many biomarkers. These are just the ones that are commercially available. and more are coming. And all of these are trying to do the same thing, which is to stratify patients who either have not yet been biopsied or have had a biopsy that showed grade group 1 or negative, to identify those patients who have higher grade cancer. And you can see they vary according to whether they're blood or urine or tissue based. They vary according to cost. The area under the curve for finding grade group 2 cancer is remarkably similar, somewhere around 0.7 to 0.85. At the moment, the Select MDX assay has the highest area under the curve. But just to emphasize, these have never been compared head to head. We are actually doing a head-to-head comparison in Canada at the moment, but no data yet. So they all work. None of them are perfect, but they all add some value. So first of all, some concerns about the tissue-based biomarkers. So these are the most expensive ones. And what these tissue-based biomarkers involve is microdissection of the low-grade cancers from the slide, and then a series of molecular assays, genetic assays performed on those microdissected cancers. Because it's quite labor-intensive, these are expensive assays, around $4,000 US. And they do add value, but there's a major caveat or a major concern, and that relates to the heterogeneity of prostate cancer, because these patients by definition have multifocality. You are looking at a biopsy to see if they have a higher grade cancer somewhere else. And there's now several studies that all show the same thing. This is one of them. These are patients, 41 patients who had multifocality. And these multiple cancers were dissected out from each patient and subject to whole exome sequencing. And the question was, of the mutations that were seen, how many are common to all the cancers in that prostate, and how many are unique? And the powerful message is that most of them are unique. So here you see the gray mutations are the ones that are unique. The orange or the brown ones are the ones that were common. 95% of the mutations are unique. So you have your patient who has a biopsy that shows grade group 1. You send the tissue off to the Oncotype genomic health people or the Polaris people, and they do an analysis of the genetic alterations. And the problem is, the chances are those are not the same alterations that are present in the other cancers in that prostate. And this is just one recent clinical study that confirms this concern. This is also from the Canary cohort group. Men on surveillance, about 40% were upgraded. No association between the GPS score, which is the Oncotype DX score, and upgrading. No association. And adding it to PSA density and diagnostic grade group didn't improve this. So this is a very significant concern about the tissue-based biomarkers. The liquid biomarkers are a different story, because they are not reliant on sampling a small amount of tissue in the prostate. And I just want to talk about one that is coming that I'm very excited about. And I am involved with this company as a consultant, just to declare my conflict of interest. But I think this could really be a game changer. This is called the Sentinel assay. It's made by a company called Mir Scientific, and it analyzes a panel of urinary exosome small non-coding RNAs. So exosomes are these microvesicles. One cancer cell may shed thousands of exosomes per day into the circulation. And these exosomes contain important biologic material, including and particularly small non-coding RNAs. And these are packaged, so it's not a random, it's not random which biologic material the exosomes contain. And these non-coding RNAs are regulatory molecules, and they vary according to the molecular genetics of a cell. So for example, they may be involved in silencing tumor suppressor genes, or they may be involved in splice variants. The V7 splice variant process is regulated by microRNAs. And this is a panel of about 400 microRNAs, and this shows the predictive value for each one of these microRNA sequences. So they vary according to the degree that they predict the presence of higher grade cancer. But when you put 400 of these together, the power of this is really extraordinary. And this was just published within the last year or so. This is the initial publication of this data. And there's these two assays. The PCA score is detects the presence or absence of any prostate cancer. This is again based on urine exosomes. This is the clinically significant score. The CS score is the presence of grade group 2 or higher. And look at the area under the curves. I mean, this is really amazing. 0.97, 0.96. This is significantly better than anything we've seen before. The best one to date is the select assay is 0.90. And this is the kind of data that I think we will be able to really rely on. It still requires validation. And you can imagine going forward. So this slide is taken from the hematopathology literature called dynamic risk profiling, where you have an accurate assay that you subject the patient to over time. You send off their urine once a year. It's a negative assay, and suddenly it converts to positive. And suddenly you have a signal that this patient has developed significant cancer. So you can imagine how this would transform the management of low-risk prostate cancer. No more need for a biopsy, and you only need to selectively image that patient with an expensive modality like MRI if they have a change in their molecular signal. Finally, this molecular approach is going to generate a lot of data on each patient, and the challenge will be to integrate this all. So another new initiative is to use artificial intelligence. There's a group in Australia that has really developed this to a very advanced degree, where you collect data on tens of thousands of patients. The data is very comprehensive, not just molecular data from urine and serum tests, but biopsy data, imaging data, PET data, the patient's germline genomics, the biochemical assays, their lifestyle, et cetera. And big data allows you to compare your patient to, say, 50,000 other patients, and it will give you a very accurate prediction for that patient having significant cancer. So this is also a tool that is coming. The final thing I'll talk about is you have your patient on surveillance, and is there anything more you can do? And patients very frequently say to me, and I'm sure they do to you folks as well, is there anything I can do to stay safe, to prevent this from getting worse? And a lot of men, particularly those with type A personalities, they don't like the conservative management strategy. They want to feel they're doing something. So there are interventions you can offer these patients, and whether they have an impact on the prostate cancer is really only part of the story, because you can, in many cases, benefit their general health as well, and it may have more impact than the effect on prostate cancer, but overall it's a good thing. So some of this is what I call motherhood. Smoking cessation. This is the single most cost-effective intervention in all of medicine. If you are a specialist, the patient has been diagnosed with prostate cancer, and he comes in and you say, "Do you smoke?" "Yes." "Stop." 2 minutes by a specialist in that circumstance has been shown to influence patients' behavior and there is nothing more useful you can do for that patient. Regular exercise. Exercise influences the biology of prostate cancer favorably in at least 8 different ways that have been demonstrated. Improvement in immune function, in hormone levels, cytokines, methylation profile, vascularization. If this were a pill, we would all be on it. It's really important to emphasize exercise. And finally, dietary modification, particularly weight management. And then this is, the motherhood about a healthy diet that everyone knows, not too much red meat, increased fruits and vegetables. Now, 2 points about this. First of all, obesity. This is becoming very subject to some very high quality science now. This is just published in the last couple of weeks in the New England Journal. Obesity and the tumor immune microenvironment. This was a study of what happens to the tumor microenvironment in obesity. And essentially what they showed is that obese men have an alteration in the tumor metabolism where the tumor cells increase the uptake of free fatty acids. And what this does paradoxically, it starves immune cells of fat, necessary fat, and it leads to so-called fatty acid partitioning and impaired tumor immunity. Obesity has been shown to impair tumor immunity, and we know that the host-tumor interaction is really critically important in terms of keeping these prostate cancers indolent. And just one more slide about this. If anyone's interested, there's the reference from Cell last year, the mechanism of this through something called prolyl hydroxylase 3. It doesn't really matter, but that in obese men, you get this metabolic alteration that may impair anti-tumor immunity. So trying to get your obese patients to lose weight, I think, is supported by solid science, aside from the other health benefits. The other question is, relates to dietary modification. Should you tell them to alter their diet to prevent progression? So we just had recently, I think, the best data we're going to have on this for a long time, a JAMA article called The Meal Study, randomizing men on surveillance between dietary intervention and a pamphlet. The dietary intervention basically said increase fruits and vegetables, decrease fat intake. Did it work? It did not work. So here you have the likelihood of rise in PSA or worsening of PSA kinetics or upgrading. Absolutely no difference out to 2 years in any of these endpoints. So I think everyone in medicine knows that your diet over your lifetime has a major influence on health. But this evidence suggests that once you're diagnosed with prostate cancer, it probably doesn't make much difference, at least in the intermediate term, whether you modify your diet or not. And then finally, and very briefly, this is for men who want to be proactive. So some guys say, I want to do something. And there's 3 interventions you can do. None of this is supported by prospective randomized trials yet, although these studies are being done. But these are all innocuous, cheap interventions that have other health benefits, and I think you can offer your patients. So this is vitamin D, particularly in northern countries, low-dose statin and metformin. I'll just briefly show some of the data. Vitamin D, now I don't know, Uruguay is probably a lot sunnier than Canada, but in Canada, vitamin D deficiency is really the norm. It's the rule in older patients. They don't get enough sun exposure. And there is all kinds of epidemiologic data. Here is one meta-analysis showing that prostate cancer mortality is increased in patients who have low levels of vitamin D. So this costs a few pennies per day, somewhere between 1,000 and 1,500 international units. I think this is worth doing. Second thing is statins. Of course, the statins have other health benefits in terms of cardiovascular disease, but there are many studies showing an association between low-dose statin and a reduction in prostate cancer mortality and metastasis. And we have good science supporting this, that the statins inhibit the mevalonate pathway, which leads to a number of mitogens like insulin-like growth factor 1 and others. So I encourage patients to go on a low-dose statin like atorvastatin, 10 milligrams per day if they're not already. They get both the cardiovascular benefit and the prostate cancer benefit. And the third is metformin. Metformin increasingly looks like a health-preserving drug, even in healthy patients. It's, of course, the old diabetic drug. It's a low dose, 500 to 850 milligrams per day. It has two mechanisms of action. It reduces oxidative stress by inhibiting AMPK activation. And it also results in lower levels of insulin and glucose, lower levels of mTOR signaling and AKT. And there is a lot of data. It's indirect. Here's 30 cohort studies looking at the relationship between prostate cancer and metformin use, mainly, of course, in diabetics. And the overall signal is very strong that there's a reduction in prostate cancer metastasis and mortality in men on metformin. We are doing a randomized study now in Canada of metformin versus placebo in men on surveillance. So that's really what I have to say. This is our management protocol. Initial diagnosis based on 12 core plus or minus targeted biopsy, MRI within the first year, PSA every 6 months. We do the DRE, it doesn't have much value. Confirmatory biopsy within a year with a targeted biopsy if it hasn't been done. Then we do the MRI every 2 to 3 years, repeat the targeted biopsy if there's a change, but for sure, patients still need the systematic biopsy. We now do it about every 4 to 5 years if the other clinical parameters are stable. And the only reason to intervene now is for grade progression tempered by clinical judgment. Thank you very much for your attention. I'd be happy to take some questions, and I'm sorry if I've gone over time.
Bueno, un gusto como siempre, Laurence.
A pleasure as usual, Laurence. You walked us through all the potential possibilities of active surveillance currently. We know that you have something else to do, so we put the meeting earlier. In the audience, I don't know whether Daniel Castellano is with us. He needs no introduction in uro-oncology. He came to see you today. He is a great friend of ours. And then maybe there are some questions in the chat that I think you answered as you went. Laurence, in your daily practice, how important do you think it is when a PSA goes up? Isn't that a criterion for an active treatment? Could that be a criterion to decide to do the biopsy earlier?
Yes, so that's a great question. And our view of this has changed over time as we have better evidence. So as I mentioned, we used the PSA kinetics, a doubling time less than 3 years, as the trigger for intervention for a long time, but it didn't work. And the reason was half of the patients who had a doubling time less than 3 years or a rapid rise in PSA had absolutely nothing going on. It was an artifact. So it is not specific enough. On the other hand, of the patients who do badly, they mostly have poor PSA kinetics, rapid rise in PSA. So it is sensitive but not specific. So we use it, as you say, it's a trigger. Repeat the MRI, repeat the biopsy, but we do not, nowadays, we never treat a patient only for a rise in PSA. And I have many, many patients in my practice whose PSA has gone from 10 to 15 to 20, even more. And we are continuing to follow those patients. So, you know, in most of the patients, eventually you find something and then you treat it, but not in all.
Muy bien, creo que es un concepto
Very
compartido.
good. I think it's a concept we all share. In the past, we got very frightened when PSA went up, and we get less and less frightened. Any other questions? We have Juan Pablo Sade among us. Juan Pablo, would you like to make any comments or questions for Dr. Klotz?
Hola, perdón, no sé si me escuchan. No tenía muy buena señal. ¿Cómo están?
Hello, sorry. Can you hear me?
Yes.
Yes, go ahead. In Spanish? Should I do it in Spanish? Yes, as you like it. Whatever is easier. It's the same, Juan Pablo. Okay. The question is, to what extent do you think that the not absolutely satisfactory results with MRI, incorporating MRI, have to do with technical issues as to how MRI is performed, or whether it's a problem of experience, learning curve, when they report it? So it's not a problem of the method itself, but how it's reported.
So I think it's both. All of these things are important. So one of the problems with MRI is there is a big learning curve at every step. The interpretation of the MRI, the fusion targeting, there's the risk of error in both. But I think there's also inherent limitations to MRI. It does not detect many small high-grade cancers. And the data is crystal clear about this from many centers of excellence, that if you take a group of patients, for example, with intermediate risk prostate cancer, you compare the MRI to the radical prostatectomy, many of these small cancers are missed. Now, it's much, much better than no imaging, but we need to recognize its limitations. The other thing, as you imply, there's also the technical issues. So if a patient has, for example, a hip prosthesis, or if the machine is not tuned properly, there's a lot, it's a very complex piece of technology. And this is my understanding. Some days the MRI works better than other days, related to the function of the supercooling coil, for example. It's a very delicate piece of technology that doesn't always function the way it's supposed to. So I am not trying to minimize the value of MRI. It has a lot of value, but I don't think it has really quite met the expectations we had, say, 5 years ago. People called it the GPS of the prostate, that this would map out exactly what is going on. You would see every high-grade cancer. It's not that good. By the way,
pregunta, si me permitís, Levin, una pregunta más. Muchísimas gracias, Laurence.
Levin, one more question. That was absolutely clear, Laurence. Another question in the same direction. In our regions, conducting a PET is increasingly affordable. It's not as expensive as in North America. Do you think that PET could play a role or in the future, or whether it makes sense to study it further to select patients?
Sorry, I'm not sure I understood the question. Are you asking about MRI?
No, PET SMA.
Oh,
PET.
PET.
No.
Yeah.
See.
In
No,
South
PET.
America. Yes. Okay.
PSMA PET. So
Yes.
I was going to talk about that. I mean, PSMA PET is a huge advance. The question is, in localized disease, does it have value? And I would say we don't know the answer to that yet, for sure. But the data we have mainly comes from Australia, is that for localized disease, untreated prostate cancer, it is no better than MRI. I think it definitely has a role for patients with recurrent disease, but at the moment, I don't think it has a role for detecting localized disease any better than MRI or probably high resolution ultrasound. Now, maybe it's no worse. So if it's widely available and inexpensive, then it might have a role. But I can tell you in my world, it's not available for localized prostate cancer. It's only available in a restricted way for patients who have recurrence. So I'm not that excited about it for localized disease.
Muchas gracias. Muchísimas gracias.
Folks, I'm going to have to say goodbye. I've got a case waiting for me.
Laurence, muchas gracias por haber estado nuevamente.
Wow, thank you. Thank you for being with us again.
Okay.
And hope to see you again personally in Punta del Este.
Okay. Please invite me to Montevideo in person sometime. I'd very much like to come.
Sin duda, sin duda.
All right.
No
Bye-bye.
doubt, no doubt. Bye.
Bueno, amigos, muchas gracias a todos por haber estado. La verdad que estos cambios de horario nos cambiaron un poco la dinámica en la mañana, pero bueno, a los que les interese, como siempre, la masterclass va a quedar grabada, está accesible en la web de la cátedra www.catedradeurología.edu.uy y va a quedar grabada a partir de mañana, seguramente ya la podemos ver. Un gusto enorme haber visto nuevamente a los mismos amigos que a lo mejor no veía desde el año pasado por Zoom, y estaremos presentándoles para el mes que viene una nueva masterclass. Lo haremos simplemente una vez por mes. La verdad que yo honestamente creo que estamos todos un poco saturados de los Zoom, así que en el intento de mantener las conexiones con los colegas de todo el mundo, vamos a seguir haciéndolas, pero en un plan un poquito más liviano, de una vez por mes, siempre el primer jueves, y la verdad que en horario de la mañana, que es el horario que nosotros nos dedicamos a la academia en Uruguay, porque personalmente me niego a hacer un Zoom a las 8 de la noche, donde creo que todos deberíamos estar en actividades lúdicas y en alguna otra actividad que nos haga mejor a nuestra vida. Así que nada, si alguno de los presentes quiere hacer algún comentario o tiene algún comentario, los micrófonos se pueden abrir. Gracias a los colegas oncólogos por estar acá, a los colegas radioterapeutas, a los residentes de toda Latinoamérica que siempre están, los colegas uruguayos y argentinos particularmente, el grupo de Mendoza que siempre está. Bueno, ya vimos a Daniel y a Juan Pablo de ese grupo. Y bueno, nada, agradecer, veo que Gabriel al final, un poquito tarde, pero se pudieron conectar. Así que bueno, nada, esperemos que nuestro próximo invitado nos pueda mantener, pero la verdad es que por un error mío yo le había invitado a él para el primer jueves de abril, sin darme cuenta que el primer jueves se caía en Semana Santa. Y lo llamé cuando me di cuenta 10 días antes y le dije, Loren, ¿puedes cambiarlo para otro jueves? Y aún así aceptó cambiar. Se ve que hoy se le complicó la agenda o algo, y bueno, a la mañana temprano tuvimos que hacer esta improvisación. Pero bueno, como queda grabada la charla, nos sirve el pretexto para volver a juntarnos dentro de un mes.
Levin, unas palabritas nada más que me nombraste. Lamento muchísimo haberme conectado hace unos pocos minutos, y eso que apuramos la reunión docente nuestra que teníamos en la cátedra para terminar. Estamos con el doctor Cuello también ahí conectado. Realmente, primero, felicitarte por lo del año pasado, que fue brillante, la masterclass, y por supuesto nos enriquece a todos poder participar por distintos motivos, como decís tú, la actividad académica a veces nos es complicado los horarios, pero por supuesto desde oncología, desde la cátedra, nuestro apoyo y nuestras felicitaciones por lograr lo que ya has logrado el año pasado, Levin. Ya te conocemos y sabemos de lo que sos capaz, y bueno, en este momento que ya son 9:23, tenés todavía 66 personas conectadas. Realmente felicitaciones, y ni que hablar viniendo de vos y de Laurence Klotz, con la capacidad de este hombre. Así que, nuevamente, felicitaciones, gracias por la invitación y gracias por permitirnos estar en este grupo tan lindo de gente que te sigue desde hace tanto tiempo, Levin.
Para mí, ustedes saben muy bien, creo que es el área que más tenemos que trabajar, el realmente empezar a integrarnos y bueno, acercarnos a subespecialidades dentro de la urooncología, acercarnos a, como decía Mauricio una vez, no es cuestión de que yo te pase el paciente, es cuestión de que veamos el paciente en conjunto. Estamos trabajando para hacer eso, para lograr instancias de compartir consultorio directamente con los colegas oncólogos, ver los enfermos en conjunto en el mismo momento, o por lo menos tener una fluidez de comunicación que haga que realmente a todos nos vaya mejor, nos va a ir mejor a nuestros pacientes y nos va a ir mejor a nosotros. Así que creo que eso es redondo. Si alguien quiere hacer algún comentario está abierto, y si no, bueno, muchísimas gracias a todos nosotros. En el momento en que Klotz nos llamó, empezábamos a tomar la prueba del semestre por Zoom. O sea que tuvimos que suspender la prueba del semestre y bueno, ahora vamos a rearmar todas las reuniones por Zoom y seguiremos con los residentes. Un abrazo a todos, muchas gracias por estar y nos vemos el mes que viene.